Hello, everyone. Thank you for joining today's webinar, Pandemic Flexibilities in Long-Term Care. I am Catherine Martucci, Director of Policy and Programs at the Alliance for Health Policy. And for those of you who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. I want to take a moment to thank the Commonwealth Fund for sponsoring this event and remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. We definitely want this to be an active conversation today, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time. We will collect these and address them throughout the broadcast. You can also chat any technical issues that you may be experiencing, and someone will attempt to help you with them. And please make sure to check out our website, allhealthpolicy.org, where you can find background materials that accompany this event, including the slides, a resource list, an expert list, and a recording of today's webinar will be made there available soon. Now, I'm so pleased to introduce Dr. Gretchen Jacobson to moderate today's discussion. Dr. Jacobson is the Vice President of the Medicare program at the Commonwealth Fund. Prior to joining the fund, she was at the Kaiser Family Foundation, where she served as Associate Director of the organization's program on Medicare policy. So Dr. Jacobson, I'm very pleased to be leaving this discussion in your expert hands. Thank you so much for joining us.
Thank you, Catherine. It is a real pleasure to moderate this panel today. The COVID-19 pandemic has exposed long-standing needs of long-term care patients. A recent report card from AARP on long-term services and support concluded that many states may not be well prepared to offer affordable, accessible long-term services and support choices for individuals in the future. The COVID-19 pandemic has illustrated the vulnerability of the Medicare population and has made it all the more pressing to look at our long-term care system. Some estimates have shown that a staggering 40% of all US COVID deaths are linked to nursing homes. And in contrast, for home health care provided in the home, we have less information. And a forthcoming brief highlights the lack of information about COVID infections and deaths in home health care. Additionally, over 200 Medicare coverage and payment policies have been modified by Congress and the administration since the COVID-19 pandemic began, many of which have affected long-term care providers and their patients. While the majority of these regulatory changes were declared to be temporary when they were announced, the administration has indicated plans to make some permanent. And in doing so, it's important to understand the trade-offs in Medicare spending, patient outcomes, health equity, and provider accountability. So today, I am very pleased to have two experts that together can help us look at both health and community-based long-term care, home and community-based long-term care, and nursing home care. So first, we have Dr. David Grabowski, who is a professor of healthcare policy at Harvard's Medical School. He is also a member of the Medicare Payment Advisory Commission and recently served on the CMS Coronavirus Commission on nursing home quality and safety. Next, I am pleased to introduce Dr. Eric DeYoung, who serves as Chief of Geriatrics for Capital Caring Health, which exists to help create the skilled and affordable team that help frail elders live with dignity at home. He also serves as a chair for the Public Policy Committee for the American Academy of Home Care Medicine. Previously, Dr. DeYoung was the Director of Geriatrics at MedStar Washington Hospital Center. Thank you for joining us. We're going to start today hearing from Dr. David Grabowski. David, I'll turn it over to you.
Great, thank you, Gretchen, and thanks to both the Commonwealth Fund and the Alliance for Health Policy for inviting me to speak today. I'm going to focus predominantly on nursing homes, talk about what's the crisis in nursing homes, what's been the response, and going forward, what should policy look like in this space. Next slide, please. So I called it a crisis just now, but it's really, when we think about COVID in nursing homes, I like to say it's a crisis on top of a crisis. So let's start with that top crisis and the short-term crisis, COVID-19. So we know, as Gretchen mentioned in her introductory remarks, this pandemic has hit nursing homes, their residents and their staff particularly hard. So we've seen in long-term care facilities, predominantly nursing homes, roughly 500,000 COVID cases resulting in 80,000 plus deaths. So those are huge numbers. That's obviously about 40% of fatalities in the US have been in long-term care facilities. Unfortunately, many of the deaths and cases have been concentrated among nursing homes that care for larger shares of minority residents and have larger shares of minority staff members. So we had disparities in nursing home care before the pandemic, and this has certainly magnified those disparities. Beyond just the effect of COVID itself, the virus, the pandemic has also had an impact on nursing home care. For years and years, we've tried to make nursing homes more engaged, more person-centered, a part of the community, if you will. This has actually pushed us in the opposite direction. Residents are incredibly isolated, lonely during the pandemic. We've had to close nursing homes to visitors. We haven't had communal activities, and so we're hearing reports of nursing home residents suffering from loneliness, depression. This has had a massive effect. It turns out the virus kills, but loneliness and isolation also harm and kill residents. And so that's had a huge effect. This has not just been hard on the residents, it's been hard on the staff. We did a quick sort of back of the envelope calculation that we then published as a Washington Post op-ed, suggesting when you do the analysis, nursing home caregiver is now the most dangerous job in America, more so than logging workers or commercial fishermen. We have more caregivers, over 800 since the start of the pandemic that have died, and that's probably, unfortunately, an undercount. And then we're seeing huge declines in admissions and occupancy in nursing homes nationwide. Some of that's obviously due to fatalities, but we're also seeing this shift away from nursing homes. We see very fewer patients coming from the hospital to nursing homes, and then fewer individuals entering from the community as well. That's the short-term crisis, but we've basically overlaid that on a long-standing crisis. Nursing homes did not enter this pandemic from a position of strength. Medicaid is the dominant payer in nursing homes. They pay for long stay care. They in most states pay below costs, and so nursing homes depend on Medicare paying for short stay care to cross-subsidize that long stay care for Medicaid recipients. It's a very tenuous business model, and during this pandemic, as we've seen fewer and fewer hospital discharges going to skilled nursing facilities, we've seen that more profitable group of patients kind of dry up, and nursing homes are largely left with Medicaid recipients. We've had a long-standing history of poor quality, low staffing, a workforce that's paid close to minimum wage, lots of racial and ethnic disparities. Physicians have been termed missing in action in nursing homes. We have very poor sort of clinical infrastructure in many nursing homes. We have a lot of nursing home regulation, but it's quite fragmented and often inadequate, both in terms of the enforcement, but also just in terms of the rules themselves. And then finally, quality is often pretty opaque. It's not very transparent for stakeholders about what's actually being provided in the way of good quality of care and good quality of life. Next slide, please. So it's this crisis that we really have to view, like which nursing homes have had outbreaks to date. And I just wanted to talk about one study that we did. We published in the Journal of the American Geriatric Society a couple of months ago, but this result has largely held up, that the largest predictor of whether a nursing home has a COVID outbreak is basically where it's located. And you can see I just took that panel there on the left from the Wall Street Journal, highlighted our results, and you can see that it's really about kind of where the home is located, with a couple of exceptions. Larger homes have been more likely to have COVID cases, and when the share of Black residents is greater, they've been more likely to have more cases, which obviously, as I mentioned earlier, is part of that disparities in care. It's really interesting, however, beyond sort of these kind of community issues, a lot of kind of factors around prior quality are unrelated to whether a facility had a case. So higher rated facilities, whether they had a prior infection violation, for-profit status, chain status, their Medicaid share, all unrelated. It's really about where you are, not who you are. And I think that the key point to this is that this is a system level problem, not a bad apples problem. If we're going to help nursing homes, we really need to think about resources for all facilities. Next slide, please. I was part of the Nursing Home Commission, the CMS Commission, that was tasked by the White House to look at what could be the framework, the roadmap for moving forward out of this. And I apologize, it's small there in green, but we highlighted 10 key themes that CMS should address in order to protect nursing home residents and staff from COVID. And I won't read those to you, but it shouldn't be surprising, you know, whether it's testing and screening and PPE and cohorting, and I mentioned visitation earlier, and on down the list. But there's a series of areas, and these 10 key themes then drove towards 27 recommendations and over 100 action steps. And it's certainly the case that I wish our federal response had been earlier, and I wish that it started in March, but given it didn't start in March, the second best time for it to start is today. And I really believe that these 10 areas and these 10 key themes are a great roadmap moving forward. So these are what we suggested. What has the federal response been like to date? Next slide, please. We have seen some attention on nursing homes, as I just asserted. I think it's been a slow response and an inadequate response, but there has been a lot of relief funds directed towards nursing homes. There's also been some relaxation or waivers of some rules. For example, prior to the pandemic, we've had a longstanding rule in place known as the 3-day or 3 midnight rule, where in order to qualify for nursing, for skilled nursing care, for Medicare covered care in a nursing home, if you're in traditional Medicare, you had to have spent 3 days in the hospital. We've relaxed that rule, and I think the reason we've had that is to prevent long stay nursing home residents from just being converted over from Medicaid to Medicare. That's been called skilling in place. And so it'll be interesting to see how much skilling in place is happening since the pandemic started, and what's the impact of that. But we are hearing anecdotally that that's been an important source of resources for facilities. Federal government is currently supplying testing. They've had a couple of kind of attempts at providing personal protective equipment to facilities. As I mentioned earlier, nursing homes have been closed to visitors. That's actually had a lot of negative impacts on residents, and we've slowly seen nursing homes reopening. The federal government has invested in data and enhanced monitoring. There's been increased infection control surveying and some fines. And then we're going to talk more about this. I'm certain Eric will touch on this, but there's been a lot of flexibility in terms of telemedicine reimbursement. Which of these kind of policies could become permanent? I want to focus on two. Next slide, please. I think the biggest candidates towards what we could see going forward in nursing homes are the waiver of that 3-day rule and changing the payment rules around telemedicine, which could have a huge impact on clinical care in the nursing home setting. If I had to make a prediction, which is always dangerous, I would say the 3-day rule will go back in place and telemedicine will be made more flexible. So I think one area we won't see much change on is the 3-day rule. One area that we will see a lot of changes is in telemedicine. With the 3-day rule, why I say that is that it's been in place to guard against exactly what we're allowing nursing homes to do right now, skill in place. The concern is that if we waive this rule permanently, it's just going to open the floodgates. And some of that care will be high value, but the concern is that a lot of it will be low value care. I do think we could see some reform around the 3-day rule in terms of how we treat emergency department or observation stays in the hospital. I think that could actually be valuable to rethink why it's 3 days and what helps contribute to that 3-day period. And then it's important to note that there are some parts of Medicare where the 3-day rule doesn't apply. Medicare Advantage, of course, and accountable care organizations are two examples. ACOs often have this rule waived. And the reason that MA and ACOs don't have this rule is because they're an at-risk entity. And when you have an at-risk entity, you don't need this safeguard in place. What about telemedicine? I don't have time to talk about my research in this area, but we've found telemedicine to be very productive in the nursing home setting towards preventing hospitalizations. But the concern has always been, once again, will it introduce kind of a lot of low value services? Will it actually improve care? There have been benefits. I think this is going to be really important. Historically, Medicare only paid for telemedicine in rural settings generally, but rural nursing homes in particular. I think going forward, we're going to see some guardrails here, but we will see broader coverage of nursing home services. Next slide, please. So thanks. Final slide, and this comes directly from a piece I wrote for the Commonwealth Fund under Gretchen's direction. I think there's a lot of ways that we can strengthen that longstanding crisis in nursing homes that I discussed earlier. We obviously have to improve Medicaid payments and really better align Medicare and Medicaid such that we're not overpaying in Medicare and underpaying in Medicaid. We need to get more clinicians on site and really think about ways, whether it's telemedicine or institutional special needs plans or other payment models that encourage clinicians on site. We need to pay our direct caregivers better. The idea that we're going to pay them near minimum wage and under COVID, ask them to put their lives on the line is really led to, I think, a critical staffing shortage. Morale is down. I think the staff are incredibly fragile right now. Going forward, I would love to see minimum staffing standards coupled with better pay. We need more quality transparency. We need regulatory reform, better enforcement, and we need to link that enforcement to quality improvement and really make the regulations about what matter to patients and residents and stakeholders. I'm a big proponent of smaller home models. They've done really well under COVID, and I would love to see these smaller home, more resident-centered models be applied more often. One of the aspects of COVID that's really been drawn into sharp focus is the idea that much care, especially for the non-elderly disabled population and many older adults, is that long-term care can also be done at home. And it would, I think, be great if we could transition more and more individuals going forward into home and community-based settings. I think we're always going to need a nursing home for some group of residents. Let's make that the best nursing home possible. Resident-centered, smaller home models would be great in that regard. But these are not opposed to each other. We can both invest in home and community-based care, and I know Eric's going to talk more about that in a moment, and also make nursing homes as strong as possible. And finally, at some point our country's going to have to invest in some sort of national long-term care benefit. I hope that's I hope if there's a silver lining to COVID around long-term care, it's that we put this off for far too long, and the time is now to really focus on this area. I'll stop there and turn it back to Gretchen. Thank you.
Thank you, David. Now I'm going to turn it over to Dr. Eric DeYoung. I want to first also remind our attendees that you can use the questions panel of the audience interface to submit your questions at any time and get into the queue for the chat. I'll turn it over to you, Eric.
Thank you, Gretchen. And thanks to the Alliance for Health Policy and Commonwealth Fund for having me on as well. So I'm Eric DeYoung. I'm a geriatrician here working in the Washington, D.C. area for Capital Caring Health, which is a nonprofit that does a lot of work with advanced illness, primary care, and hospice, and palliative care. I serve in the role as the chair of our public policy committee for the American Academy of Home Care Medicine, but I'm thinking really about this population as a whole and not specific to the home or the nursing home, but how can we have payment policy that really supports care of the most sick, most frail elders in our communities and keep them safe and well cared for. So next slide, please. So the major topic is going to be long-term medical care at home. So long-term care can be done at the home, it can be done in the nursing home or assisted living. So I'm going to lay out my first goal is I think any payment policy change needs to really have the goal of a nationwide infrastructure of mobile teams that can do home-based primary care. They have to have the skills and compassion to do that kind of work. They need to be equipped with adequate technology, and they need to be available in every community. So I'm going to talk about what is possible, and I'm going to use a case of a kind of an amalgam patient of ours, and just highlight how you can do this kind of care with both high touch, in-person, physical touch, and a lot of kind of compassion, but you also need some of the high-tech tools that the pandemic flexibilities have given us. It has to be done with equity for all ill elders. As David kind of painfully points out, the minority and kind of low-income folks really have died at a much higher rate, and that their access to good primary care is also much less. Two ways to do that, however, is to eradicate the payment silos that kind of currently discourage kind of good primary care at home, and the barriers by income and education actually have some of the telehealth rules as well as just workforce availability. I will kind of make the case, the good news is that home-based primary care and kind of home care medicine as a whole has shown in multiple ways, whether it's primary care, actually hospice, hospital at home, to be able to lower total costs of Medicare by 15 to 20% when done well and when held accountable for good results. So what has been the effect of the pandemic flexibilities on kind of medical care at home? There has been a lot of relief. I think CMS deserves a lot of credit for their rapid relief on documentation requirements, allowing us to use telehealth for house calls when needed, relaxing of some privacy rules about which audiovisual tool you use. There is the hospital without walls that allows acute care at home, and I put an asterisk here because there are still some rules in the current guidelines that require, say, 24-hour nurses to be present at home doing hospital at home, which may not necessarily be necessary or feasible. And then there's just been direct funding for providers who are doing a lot of this care. I think it has given us a window to what could be a wider, more sustainable model of home-based medical care down the road. So what are the policy changes that I'll touch on both now and at the end? One, I think there needs to be serious change in fee-for-service incentives. The old saying is you get what you pay for, and I think that's been true with Medicare and healthcare delivery in our country, and we'll give a couple examples of that. The telehealth flexibility does need to persist. It has to find a way to balance the in-person value of a house call, of seeing that person where you can do a full physical exam, touch them, talk to their families, see their home environment. So all virtual, I think, is not the right way to go, but you can find a balance between in-person and virtual to be more effective and sustainable. And finally, I'll talk about value-based payments. There's probably the kind of highlight is getting really an adequate PMPM, a per member per month payment that really covers the costs of team-based care for the most ill, whether it's in the nursing home, in assisted living, or at home. But couple that with shared savings, meaning you're on the hook for whether you save total costs or you increase total costs, and you get to share in savings and be accountable for some key patient and family kind of clinical outcomes. Next slide. So the overarching goal is to serve a population that are the most ill. And I'm going to really focus, as do nursing homes in general, on those who have severe illness, have cognitive impairment. And think about that. If they're physically or kind of psychiatrically severely ill and they have cognitive impairment, they're not going to be able to do an easy Zoom link, right? They're underserved to begin with, and they're also very high cost. So this is the 5% of Medicare, maybe about 2 million of them, who generate almost 50% of the Medicare budget. So investing in these patients and this population across settings, home, and then they may need to use a skilled nursing facility and kind of integrate the clinical models, is the population we're serving. What is the need? The basic need is these mobile teams with a workforce that's interdisciplinary, medical, social work, nursing, administrative kind of coordinators who have technology to do both diagnosis and treatment at home. You can get a good pulse ox, which is now famous. You know, the pulse ox you put on your thumb, that's been a tool that home-based medical teams have been using for many years to decide if someone needs to go to the ER or not, be able to do IV therapy at home. And there's a bunch of changes that could be made for IV infusion to support more acute and urgent care at home. You have to commit to managing all of their care, 24/7, be available, a live person to do primary, palliative, coordinate their specialty care, make urgent visits, and manage their acute care. This is a full service commitment. It's not just in a silo of a place or a certain type of care. And that's the kind of team that we need to pay for in order to get good care of these folks. Ultimately, I find the kind of rubber meets the road if that team can prevent 911 phone calls. If they trust you, they'll call you, and they choose to call you instead of 911, you can often keep people at home. So home care medicine is a broad category. It includes home-based primary care and palliative care, which is kind of the area I practice a lot in, where you take primary responsibility for the population of patients. But urgent care and hospital at home has to be combined with this so you can give a full service, and the payment model needs to support all of this. You need to be really closely connected with hospice services, ability to care for people at the end of life, maybe not just in the last 6 months, but how can we integrate primary care and hospice care, and we'll talk about that. And then make sure your team has access and can support daily social and support services. Next slide. So what is possible? I'm going to give a brief story of a patient of ours, again, with some changes made for privacy. This is a 95-year-old person who was resident of a nursing home in early April. She came down with fever, dyspnea, which is shortness of breath, and confusion, and was diagnosed with COVID-19 in April. She has moderate dementia and spinal arthritis, basically wheelchair bound, and she was admitted to hospital, was there for 12 days, never went on a respirator, but had renal failure, was on oxygen, very sick, developed stage 4 pressure ulcers on her backside, but ultimately survived and was discharged to the family home for some home-based primary care. You can advance, yeah, thank you. So she's a retired teacher. She now lives with her son, and fortunately they have 24/7 aides. She's bedbound, and when we first saw her, it was nonverbal and totally dependent. You can advance. And this is what happened. So Friday afternoon, I actually made a house call and saw this person. She was hypoxic. Her oxygen was in the high 80s. She was delirious. She had these deep wounds. She was nonverbal. And it was a pretty startling event, right? So first step is to talk to the family about the goals. Does she want to go back to the hospital? Does she want to be on a ventilator? And the ultimate decision was to try to care for her at home. So what did we do? We adjusted her meds. We added oxygen, and this was a pandemic flexibility. We were able to get oxygen immediately because of some flexible rules on oxygen ordering. 24/7 availability. That son called us 12 times on Friday night instead of 911. And every one of those calls, he could have called 911. And we got hospice actually set up urgently on a Saturday. We did all of these other things at home, including DME, hospital bed, suctioning, wound care. They checked vital signs twice a day at home and reported those to us. And our nurse practitioner visited a couple days later to do caregiver training and continue to adjust the meds and the oxygen. we did have to change all our oxygen and DME from primary care to the hospice funded services. Next slide. So what are the barriers to doing this kind of care right now? So basically the number one is underfunding for team-based primary care at home and at the SNF. For example, it may be just benign neglect, but in the 2021 Medicare fee scale, for some reasons that are unclear to us, there's a 10% RVU cut in payments for house call and nursing home visit codes due to budget neutrality rules where some things have been increased and the house call and nursing home codes got cut. That's a direct incentive to decimate the workforce for doing this kind of work. That needs to change. 2021 telehealth rules, they currently are saying they're going to split up codes. So some codes for house calls are going to be allowed and some are not. The home is not allowed as an originating site, which limits what you can do with telehealth. And if you're going to go out and make a house call, you can't decide before a house call whether the code is going to be a level 1, 2, 3, or 4 code. So you're not going to be able to use telehealth. You'll err on the side of going to visit that patient, but that will potentially lessen access for patients. Keep going. The other rules that are barriers are this 3-day stay that David mentioned, where you have to be admitted to the hospital for 3 days before you can use subacute care. And there may be a reduction in the audio-only telehealth codes. And many of our patients who are poor or low income don't have audio-visual capability. So audio-only is important. So this is an example of incentives. You get what you pay for. So there's the biggest glut of doctors, and I love them dearly, are cardiologists and GI doctors, and they get paid a certain amount of money for a similar amount of time as that a house call makes. There's lots of other good reasons to go into cardiology and GI, but part of the reason I think students go into these fields is to help pay their loans and because of the financial incentives. Home hospice is a great success story of this. It's quite well funded. It's about $170 a day, close to $5,000 a month, and they have to pay for a lot of things, but not necessarily inpatient care. And that is, I think, partly why there's hospice services in every corner of the country. House calls, by contrast, for primary and palliative care might get $200, $250 a month, whether it's fee for service or even in the PCF payments that are coming out soon. Next slide. So what is possible for this woman? Let's just finish her story. She got twice weekly visits by both the hospice nurse and or the nurse practitioner. We adjusted her meds and her oxygen, managed her bowels with severe constipation, complex wound care, got 24/7 support. We retested her for COVID at home several times until she was negative and did blood tests. In July and August, she's actually improving now. 4 months into this, she gets more weekly visits, lots of in-person contact, including some telehealth visits, social work to help the caregiver manage. Now we're starting to do rehabilitation with PT, OT, and speech that was private pay because there's not as much access to that in hospice. So she had improved function. And now in September and October, can advance. It's 170 days since that first house call. Her stage 4 wound has healed. She's interactive. She's enjoying music and TV at home. She's eating well. She's off oxygen. She may actually graduate from home hospice. And so how did this work? So she has had at least about 13 to 15 medical visits between the doc and the NP, 40 plus hospice nurse visits, PT and OT, all the other services that were put in place at home. So this is how it's possible. You can do this at home. She spent 100% of her days at home, 170 and counting. She feels much better. She's had 0 ER visits and hospital admissions, and she has a lot of peace of mind for both her and her son. Next slide. So what policy changes are needed to kind of replicate this kind of care across the country, whether it's in the nursing home in combination with the home or just in the community? Basically, I think policymakers need to recognize the value of long-term team-based primary care for the most ill subgroup of people and pay for it. The fee-for-service chassis is still the core of this. To change behavior and build a workforce, we definitely need to stop the 10% cut in the 2021 primary care codes for both house calls and SNF visits. I would recommend for a substantial increase in workforce, increasing the value of those by at least 20%. But at the very least, a 10% increase would give us a chance at more sustainable practices. In telehealth, we need to keep all established and domiciliary codes in categories 1 and 3. Allow the home to be an originating site and keep the audio only option. I would make the case, however, that initial visits, maybe after the PHE, should be in person, because there's nothing like seeing someone in person to have the trust and knowledge of their home environment that you need. And finally, on the value-based side, you can't just give fee-for-service funds indefinitely, right? Because there are risks for fraud and overuse. I think you need to hold providers accountable for results, not for process, not for checking different boxes, but do they keep people at home? What is the % days at home of their population? What's that patient and family experience? And what's their total cost of care? Then pay an adequate PMPM for the cost of this kind of care. In our case, it's in the ballpark of $400 to $500 a month. Do shared savings and use concurrent risk adjustment so you really reflect the correct serious of illness. And finally, I'll just close with removing that 3-day rule for better SNF use so you don't have to use the hospital as much. And that's true in many value-based programs. So last bullet, I think there's one more. If you could go back just really quickly. Yeah, my last bullet there is the aspirational goal is to integrate payment models for team-based primary care and hospice care. So rather than have these silos where you're paying a very different way for primary and hospice care, figure out a way to integrate those payment models so you're not having to force a prognosis of 6 months in order to get that kind of great interdisciplinary care. Thanks for your attention, and I know we're glad to answer questions.
Great. Well, thank you both for giving us lots of fodder for discussion today. I want to remind our attendings that you can use the questions panel to submit your questions at any time. I'll start with a few opening questions for both of our panelists. So Dr. Grabowski talked about a crisis on top of a crisis to reflect interactive effects of the COVID-19 pandemic and racial disparities. What do we know about racial disparities in nursing homes and home and community-based settings? What are some key barriers to access, and what policy solutions should we look for?
Yeah, I'd be happy to start, and then maybe Eric could go second. So it's actually interesting. Nursing homes, we have 15,000, almost 16,000 nursing homes in the U.S. I like to say this just to give you a frame of reference. We have more nursing homes than Starbucks in the U.S. Nursing homes are highly local. They've been found to be our most segregated healthcare institution because they're so local. We have about 6,000 hospitals, to give you another benchmark. So these are going to be much more neighborhood focused, much more local. They draw their staff from that local area and their residents from that local area. A lot of research suggests distance is the most important factor towards predicting where individuals choose to receive nursing home services. So nursing homes are already highly segregated. A lot of evidence, Gretchen, suggests that those nursing homes caring for more African-American residents have lower quality, more deficiencies, more Medicaid recipients, more hospitalizations, fewer staff. You name the quality measure, it's unfortunately not very good. So and this was all true prior to the pandemic, but then once again, we know the areas of the country, even in local markets, that were particularly hard hit. They were often communities with lots of minority residents. That then led to some of these individuals working in nursing homes, staff members bringing it into the nursing home, and so we've seen these same disparities, and they've been heightened. Final point: how do we address this going forward? This is such a key area and something that's been longstanding. Unfortunately, I think it goes back to what Eric was suggesting. We get what we pay for. We all too often in these communities, we've asked the nursing homes to largely care for 100% or close to 100% Medicaid recipients. That's just not going to work, and these facilities end up providing lower quality or actually closing. This model of having short-stay Medicare cross-subsidize these longer-staying Medicaid recipients just doesn't work. And I think COVID really highlighted what happens when the Medicare patients stop nationally, but this has been true in these facilities caring for greater shares of African American residents for a long time. And so we need to figure out ways to enhance reimbursement and resources in these facilities. And I really hope this is a policy priority. Some of this is obviously providing more resources across the board to facilities, but really highlighting those facilities that are more concentrated in terms of Medicaid and oftentimes with higher shares of African American residents. Thanks.
And Dr. DeYoung, do you have anything else to add?
Not too much about the nursing home side. I think Dave is exactly right that it's concentrated and reflects the communities often that these folks live in and the kind of racism or low income that they've already suffered from. But I think what's kind of the good news is that if Medicare were to think about integrating payment models for primary care in the community, nursing home payment, hospice payment, you could develop interdisciplinary teams that help keep these folks in the community, at home, with a lot of intensive nursing, medical, and social supports. But it would really require rethinking how CMS and Congress pay for care of this really high-risk population. DC is a great example. There's very little primary care in kind of the Ward 7 and 8 Southeast area, and there's tons of doctors and primary care people in the Northwest DC. So it's really kind of incentivizing the workforce to go to those neighborhoods and work there that I think can make a big difference.
Great. So moving to telehealth. So colleagues who've written for the Commonwealth Fund, Ativ Mehrotra, one of Dr. Grabowski's colleagues, talked about how much of the rise in telehealth during the pandemic was supported by regulations and rules that have been changed by Health and Human Services. What do we know about the impact of these changes on long-term care? And are all patients benefiting equally, or where does telehealth really not make sense for this population?
Yeah, so I think inevitably that huge rise that Dr. Mehrotra documented, some of it is being directed to nursing homes. We've had, as I noted in my earlier presentation, historically huge barriers to delivering services in this population. One of my favorite studies, we did a randomized study here in Massachusetts that found huge benefits to off-hour telemedicine coverage. We were super excited about it. We published it in Health Affairs, and we were really just super amped up about the results. And then right after we published the paper, the nursing home chain actually stopped the telemedicine service. They decided that they could no longer support it just because they were paying the cost of the telemedicine, and the benefits were going to the Medicare program and fewer hospitalizations. And so we had found the successful study, but as Eric said earlier in his remarks, it was fragmentation and payment that really doomed it. And so I once again go back to this idea: if we can align payments, and whether that's within MA, Medicare Advantage, if that's an accountable care organization, there's real opportunities for telemedicine. I still hear a lot of concerns about applying telemedicine in a fee-for-service world, and I think Eric did a nice job during his remarks sort of talking about some of the challenges there, because it does encourage high-value use, but there's also this concern about low-value use of those services. And so I think telemedicine will have some guardrails built into it going forward in the nursing home setting and more generally, but we know it can do a lot of good in terms of encouraging better primary care, discouraging transfers to the emergency department and the hospital. So I'm very bullish, Gretchen, but very worried that policymakers will be very focused on that inappropriate use. And I do think this is an area where value-based payment models can really encourage high-value use as an at-risk entity. But I do think we're going to see expansions even in traditional fee-for-service.
I would just add, Gretchen, that I think a blank check and fee-for-service for telehealth is probably not a great idea, but you also have to, so in value-based world, it's much easier to hold people accountable for the results of that kind of telehealth work. I will say the process in which the current codes are set up for 2021 is that they fragmented like a level 2 code. You can do telehealth, but a level 3 and 4 maybe you can't do. I think fragmenting the codes into what is allowed for telehealth, what's not, is not practical on the front lines. And so I think it has to be partly holding people accountable for the results, but then giving fairly flexible use of that tool within a practice.
So talking more about what you brought up, David, with regard to nursing home outbreaks being correlated with the COVID outbreaks in the community more so than any particular characteristic of the nursing home per se. So how should the public assess if a long-term care setting is taking appropriate steps to ensure the safety of its residents? Should they look at the quality ratings? Is there any correlation with that? Or is there any other information that they can really use to figure out what's the risk of their long-term care setting?
Sure. So I'm glad you circled back to this, because this has been a huge policy issue. Who's to blame when there's an outbreak? And as I mentioned earlier, a lot of data suggests we shouldn't point the finger at particular facilities if they have an outbreak, but that's not to say that we're absolving them from any role in this. And I think the key factors are, one, do they have access to personal protective equipment? We did a health affairs study that we recently published suggesting about 1 in 5 facilities have severe shortages in personal protective equipment. Do they have access to testing? We know that most facilities don't have that rapid on-site testing. And then finally, how are they supporting their staff in that same, and what is the supply of potential staff? In that same health affairs piece, we found, once again, that same number, 1 in 5 facilities are experiencing a severe staffing shortage. That's unacceptable. There's some really good data, a couple of different papers that have found that although all facilities are at risk of having cases, COVID cases in their nursing homes, the number of staff can really be one way of preventing a huge outbreak, and that makes a lot of sense. You need staff to help cohort. You need staff to spend all that additional time it takes to doff and don PPE, to get testing. If you're understaffed, there's going to be shortages and there's going to be quality of care issues. That was true pre-COVID, but I think that's only been magnified under COVID. So I think I would want to look at PPE, access to testing, and then what does the sort of workforce look like? And you know, if I could just add on slightly, Gretchen, going into the fall, people ask me like, what kind of keeps you up nights? These days, lots of things keep us all up nights, but I think that the big one with nursing homes is just the fatigue around the direct caregivers, and they've been at this now for 6 months. As I mentioned earlier, many of them make close to minimum wage. We haven't valued this workforce for a long time, but in COVID, it's really exposed what we're asking of them and what we're giving back to them, and there's a huge gap there. And I think moving forward, raising their wages, making certain they have the requisite benefits, making certain they have the PPE and the testing. Otherwise, my fear for the fall is if we see spikes here in Massachusetts and in the Northeast, other parts of the country, we're going to see some real exodus from the workforce, just given this fatigue among the staff. I don't know, Eric, if you have similar thoughts on the home care front.
Yeah, and I would actually just highlight what you said about in the nursing home. So as first, David, is that the heroes of this whole story are the staff are continuing to work 8 12-hour shifts in a hot spot or in a high-risk area like a nursing home, and they are doing incredible work, but they're kind of under the radar. They're not really being recognized for that. The piece of good news is that when I had 3 nursing homes I worked in over the last 6 months out here, 2 with high income, mostly white clientele, and 1 with low income dual eligibles. The good news is that when all 3 of them used universal precautions, had adequate PPE, got some decent staff, and they all had good leadership, all 3 of them went from kind of a 30% positive cases in the facility with 10 or 15 deaths to 0. So it can be done in both low-income facilities as well as high-income facilities, but they need the financial support. I think you should honestly double the hourly rate for the certified nursing assistants and the aides. the most dangerous job in America, and they're getting, you know, 12, 15 bucks an hour at most. But it can be done, but you really have to address the frontline staff, as David mentioned.
Gretchen, if I could just add, sorry, we're playing ping pong here, but I was just thinking, that was really well said, Eric, and I just wanted to add on one final point. I had the opportunity during the pandemic to testify at a House hearing, and alongside of me was a frontline worker from Connecticut, and she had the best line that I just wanted to quote her today. She said, "We don't need another pizza party, we need PPE." And it's really true that when we provide these resources to our direct caregivers, they can protect themselves. And Eric's exactly right. It's about you can do this in any facility, but they need those resources, and that's why I've been framing this as a system level problem. Thanks.
I want to add one point, Gretchen, just about home-based care. We've had 5 in our practice, not a lot, 5 patients with COVID-19 aged 82 to 98. Interestingly, all 5 have survived. They've had pretty minimal exposure to families, and the small room, the small greenhouse kind of approach that David might kind of alluded to earlier, having people living in individual homes or private spaces has a big impact on whether people survive and the dose of the virus that they get, but also kind of how much individual support they get going forward.
Yeah, and along those lines, I mean, we really don't know to what extent COVID has affected home health care and home health care workers and lack of PPE. There's just less information about that. Is there any other information that you would highlight that we should have going forward during this pandemic?
Let me just add one. Again, it's not published, but at our institution, our Chief Medical Officer, Dr. Matt Kestenbaum, and a whole team here have put together universal PPE since kind of mid-March. And with several thousands of patients and about 1,000 staff, we haven't had a documented case of transmission between patients and staff with the use of universal precautions in a home environment. And so I think it's just a real world example, but I think in the home environment, it's a little bit easier to keep people safe than when you're in a highly dense, kind of closed environment.
Gretchen, you're 100% right. I think this is one of those areas where we've focused a lot on nursing homes because in some ways we have the data. We know a lot. We know something about assisted living, but less. And then I think moving out to the home and community-based settings, I think we know almost nothing. And so this will be a big research focus. One point I did want to make, however, and we're already beginning to see some Medicare data about where individuals are going after the hospital, and this won't surprise anyone. You know, inpatient hospitalizations have been down since the start of the pandemic. Admissions, as I noted earlier, to skilled nursing facilities are also down, and home health, at least early on in the pandemic, was down. It's just across the board. What's interesting over the last couple of months where the data is available is that home health is starting to come back. And I wonder, Gretchen, it's going to be really interesting to follow how long this sort of change will persist, right? That individuals have always wanted care in the home. That's nothing new, but this idea that with the pandemic, being able to be in your own home, you need the services, and that's exactly what Eric has been speaking about. But is there this opportunity to shift from skilled nursing facilities to home health agencies for that post-hospital care? I think more so than ever before, we're going to see that, and it'll be interesting to follow what that means for quality and patient outcomes.
So along following that train of thought, it seems like everyone on this panel agrees that the residents should ideally stay in their home or in the community for as long as they possibly can. But as we've talked about, the reimbursement system doesn't always support that, and in many instances might actually discourage it. So what changes should we be thinking about in terms of how we pay for home visits? What else is needed in terms of support for people receiving care in their home? How would you add on to that?
Yeah, thanks. I can take a crack at that, Gretchen. I think that there's kind of, I mentioned it briefly, there's 3 major changes I think we need to think about. Is really bumping up the fee-for-service chassis of paying for home-based medical visits. The travel time that's required, the time spending in the home, it just is a more expensive way of doing primary care for a subgroup of people. So that's one. Probably more importantly is actually paying a prospective payment for a team of people. Not too different from how hospice is paid, right? That's a significant higher per diem, but pay a prospective payment based on costs of doing good team-based care in the home so that you can be in the black. Most nonprofit house call programs around the country are not able to break even. So it's hard to convince young people to go into the field when you can't really say you have a break-even proposition to do this kind of work. But hold them accountable with, say you pay $500 per patient per month for the team-based care. Hold them accountable for total costs of care and for some key metrics like days at home, patient and family experience, and really shift to a population approach. And then they can use the SNF when they need to use the SNF without a 3-day stay. They can use the hospital or the ICU when they need to use the hospital, but you reward the right behavior to help the medical behavior anyway to keep people at home. There's a whole separate question about having adequate aid support, the daily home health care aids, and that's more of a feast or famine, where if you have a lot of money, you can pay 24-hour private aids. If you're on Medicaid, you may be able to get some aids, but everyone in the middle often is kind of is struggling to get those daily home health aids, and that's a bigger question beyond the Medicare coding.
Yeah, no, just to add on to that, I was going to speak to the long-term care side of it with the caregiving aids. The data we've seen, we have about 1 million individuals nationally on the wait list for Medicaid home and community-based services. So there's a huge demand for those slots, and in many states, those individuals who are receiving those services, it's not around-the-clock care that Eric just described. It's not that private duty where they can afford. It's a very kind of narrow benefit, very service-oriented, helping with activities of daily living versus that longer sort of companion care that many individuals need in that setting. So I hope that we reorient. We've historically financed nursing homes much more than home and community-based services. There's been this huge kind of push over the last 15, 20 years to quote unquote rebalance Medicaid towards home and community-based services. But I think we have a long way to go on that front. And I had the opportunity to visit prior to the pandemic, of course, the Netherlands, and really get a window into their long-term care system. They spend about double what we do as a percentage of their gross domestic product on long-term care. And to Eric's point, once again, you get what you pay for. They get lots of home and community-based services, and it's a really rich set of benefits. And indeed, they ration nursing home services. And provide lots and lots of home care. We do the opposite. We're pretty generous in terms of not in terms of what we pay for nursing home, but allowing you onto that benefit in Medicaid. Yet we ration home care. I think they have it correct. We have it upside down. We need to borrow, Gretchen, from that model and complement it with the kind of clinical services Eric was describing earlier.
So continuing that thread, I mean, there are models, additional models for home and community-based services like PACE, Medicare Advantage plans have more flexibility with this regard to provide caregiver support, although we haven't seen them take up that option to a large extent. Are these models that can really be built upon, that can really help to feed into the long-term care system, or should we really continue to think of them as separate types of models?
I'm happy to go first on this one. I would love to see some growth in those models. PACE is a great model. Unfortunately, it's very narrow right now. I'm always struck at MedPAC when we look at the number of beneficiaries in these different integrated models, and we see the skilled, the SNPs, the special needs plans. We see the integrated, the financial alignment initiative, and the integrated Medicare Medicaid plans there. PACE is a small fraction of those models. Of course, it's a truly integrated model, whereas some of these other models say they're integrated, but as we know, some of the special needs plans are better than others in that regard. So I do think PACE and the supplemental benefits through Medicare Advantage could be a sort of an important plank in a broader set of services. I think the key question, Gretchen, is how do we kind of grow those different options, because we just have so few individuals in them right now, and how do we encourage enrollment? Because I've been frustrated. We did a study of the financial alignment initiative, and it was hard to get a lot of dually eligible beneficiaries into those models. Some states did better than others, but it's surprising. For many, they want to stay. Many duals want to stay in fee for service because of the coverage and the lack of cost sharing. And I don't know how we make that case that models like PACE are better, but they've got to be better for beneficiary. We've got to be able to get that enrollment. We can't, researchers like us just can't keep telling everyone it's better. That we have to see that in terms of enrollment. So I do hope, and the final point I was going to make is that there's such a demand among the Medicare population for long-term care. I've seen this, with the Eric mentioned hospice earlier, but MedPAC's been doing some work on hospice, and as both of you know, that benefit's been sort of the type of individual enrolling in hospice has really changed from a cancer benefit to much more of a population with Alzheimer's and other dementias. And it almost feels like some of that expansion has been this need for home care and other services that just aren't there. Some of that is palliative, but some of that is really kind of just that long-term care. And so we have a lot of Medicare beneficiaries whose needs aren't being met. And I really like the way Eric framed that. Some of our beneficiaries can afford out of pocket to do this, but and some have some Medicaid, maybe not enough Medicaid, but there's too many, that kind of forgotten middle there. They need services. And then I do think we could make the Medicaid benefit much richer.
I would just add, Gretchen, I think just to give us a fighting chance, you have to kind of just pay a team for primary care in the community enough so that they can break even or have a little bit of margin at the end of the year. And PACE is a great program. It requires several million to invest in a PACE center. It's senior center based, which may be more difficult now in COVID-19 era. I think kind of PACE without walls as kind of a philosophy of building teams that, again, that aren't micromanaged, that you have to have these 11 staff, but hold them accountable for the results. Has to be enough to cover team-based primary care. And then that team can do a lot of great work in the community with the family, finding AAA resources, seeing if they're eligible for Medicaid. You just need that core primary care team to be kind of thriving in the community, and they can find the resources to help the families, do what it takes to keep that person at home.
So switching gears a little bit with another question from our attendees. Can you talk a little bit more about the impacts of social isolation on the mental health and well-being of older adults during this pandemic? So there's been plenty of concern with data showing the intersection of social isolation and medical complications. So given where we are and the fact that we may be in this for a little while longer, what do we know about the trade-offs, and how can we balance making people not socially isolated and infection control in long-term care settings?
Sure, I could start on this one, but I'd love to hear Eric's perspective as well. I think early on in the pandemic, like a lot of other folks, the minute we learned about COVID and just this, how dire it would be for nursing home residents, I think we all swung the pendulum towards safety and infection control, and let's lock down these facilities and communal activities and visitors. I think all of us wanted to kind of build a wall around these nursing homes, and I think that made sense in the early period as we were still learning about the virus. But this issue, I've been speaking a lot about COVID in nursing homes over the last 6 months. This is 6+ months, and this is the issue I hear about more than any other. Just family members, others reaching out saying, just the negative impact that the lack of visitation engagement has had on the residents. And I think that pendulum, Gretchen, has swung too far towards safety and not towards resident dignity and quality of life. And I think we've now learned a lot more where we could actually do visitation safely in a lot of markets. Nobody's suggesting in the middle of an outbreak bringing visitors in. I think this is being safe. It's being more nuanced. But in parts of the country where community spread is lower, where the facility has resources around PPE and testing, there's no reason family can't come in. And most staff, they realize it's time consuming to kind of get family into the building, but they know the benefits that it has for the residents themselves. We've just seen so many reports of depression, failure to thrive. It's really sad. And there's a great report that Altarum released just last week, where they did interviews, sort of a qualitative study of just talking to residents and what impact this lockdown has had. And it's put it bluntly, it's a really tough read just to hear how hard the lockdown has been, the pandemic has been. As I said during my remarks, we know COVID kills, but it turns out this pandemic more generally has also killed by really cutting off a lot of residents from their families. And Eric mentioned greenhouse. I'll just say quickly as my last part of this remark that we've come a long way. We have a long ways to go with nursing homes sort of beginning to become kind of more resident directed. Really, culture change has been one of the great steps forward in nursing homes. Once again, lots of work to do there, but every step, all the progress that we made has really been pulled back. And I'm all for good infection control, but I think there's ways that we can balance good infection control with resident quality of life.
Yeah, I agree actually completely with what David said, and I would even take it a step further. I think that at least in our practice, we have seen tremendous amounts of depression. I've seen dementias get worse at a faster rate than I would expect them to get, functional decline. People saying to me, it's really not worth living. This one woman at a senior community said, I feel like I'm just in a prison waiting to knock off, so what kind of life is that for these folks? The good news is that with basic precautions, we can allow visitation. We can allow physical contact even. I read an interesting study about hugs. Brief hugs when you wear a mask are safe. So since I've read that, I've been hugging my mom, I've been hugging my family, or when I go visit people, we can hug. If it's brief and you wear a mask, that's fine. So I think it was understandable that we reacted the way we did, but now I see in the senior community this morning, I was at the Residents Association were lit into me today because they said everyone around here is depressed, they're walking with their heads down, they have no joy in life. And I think we can follow basic precautions and bring some joy back to life.
Okay, that's a really important point, I think, especially as we go forward during the pandemic. This is another question from our attendees on a bit of a different thread. So there's been increased attention to how healthcare is contributing to climate change. In the long-term care industry, part of these conversations, how are these conversations around climate change being addressed, or is that not really part of the conversation? No, it's a very different thread to this conversation, but an important component as well.
Yeah, I've been asked a lot of questions. I can honestly say this is one I've not been asked, but I'm happy to think through. I probably think like a lot of other parts of our healthcare system, the long-term care system probably has a lot of work to do around climate change and how we think about delivery and balancing that with many other objectives. And I'm just trying to think through, you could think about some of the benefits of having individuals in congregate living situations that might be good in some ways in terms of resource use and climate change, but bad in others. And so thinking about these trade-offs, Gretchen, of having home care or physicians that are driving out to people's homes, I don't think that in and of itself is a reason not to move towards the home in the community, but certainly something to really think about. And I don't know, this would be a really good question for nursing home operators. I think a lot of our capital in nursing homes is really old. Facilities built in the 1960s, 1970s. Certainly we could do a lot. And when I look at some of the small home models and just some of the innovations that are happening just in the physical plant alone, I have no doubt that we're sort of, it's a more sustainable model that we have today than these big institutional buildings that we had in the 1960s. So I love the question, and it's something I'll continue to think about, because it's not an area. It seems like, Gretchen, this could be a whole other issue brief in your series. That's climate change and health. So I don't know, Eric, if you have thoughts.
I think house calls are probably pretty low on the list of causes of climate change. But in the benefits of house calls, I think that if you have a team out there that's kind of the early radar, so in heat waves, for example, in the summers in major urban areas or in rural areas, having that early radar of aides, community health workers, NPs, and docs to be out there, getting air conditioners in, getting hydration properly done. So for the heat effects of climate change, I think the home-based medical care is a crucial tool.
Okay, so as we're sort of approaching the end of our time, I want to remind our attendees that they can still put questions into the chat box for us to address as well. But I also want to ask our panelists, as we sort of come to a close, are there any thoughts that you want to leave us with, or anything that you'd like to emphasize? We've touched on a lot of different topics during this discussion.
Yeah, I'll go first. I think there's this idea that either one, that the long-term care broadly, but nursing homes, it's inevitable, and I don't at all feel that way. I think the data supports, and I loved, Eric's anecdote about the 3 facilities and how when they got resources, personal protective equipment and testing, and we're able to cohort facilities across the spectrum are really able to respond and protect their workforce and the residents. And this can be done. And I wish we'd started back in March with these kind of activities, but we can start today. And so I would just stress that it's definitely not too late to put into place a lot of these protections, but it's going to take resources and very directed resources, and it's going to take leadership. And I hope kind of going forward that we're able to get the resources and then hold these facilities accountable. Nobody's letting any of the providers off the hook. We're going to give them resources, but ask a lot of them in terms of paying their workforce and protecting the residents and providing good quality care. Thanks.
Gretchen, I guess I would just first say I think we should give credit to CMS and Congress for making some changes very quickly and early on in the pandemic so that we can kind of do things on the fly and take better care of people. But that being said, I think for the future, for home-based primary care and medical care, to try to keep people out of the nursing home and keep people in their homes as long as possible, you do get what you pay for. I think we need to invest in this team-based approach to primary care over years, not just the last few months, where hospice has done a great job, but figure out a way to do that similar type of prospective support for team-based primary care for social, nursing, and medical staff in the home. And if you put those teams out there, they can really work magic with families to keep people safe at home until the last day of life. And I guess a couple of specific examples, I think this 2021 Medicare fee schedule for both nursing home E&M codes and house call codes really needs to be fixed promptly so that we don't lose a lot more workforce of doing that kind of care.
Well, this has been great, and I think both of you highlight the need for more resources, which of course is always at odds with making sure that we're preventing fraud and abuse of those resources and making sure that we're allocating them in the best way possible, which is always an ongoing challenge. And that was brought up sort of as our last question here by an audience member of how do we ensure that there's flexibility, but also prevent fraud and overutilization, particularly with an eye towards the solvency issues with the Medicare Trust Fund and sort of lack of funding in that way.
Yeah, sure. Pointing to the two issues I really focus on that are good candidates to going forward to become permanent, the 3-day rule in telemedicine. I think in both of those instances, simply relaxing all the all the constraints and opening this up, as Gretchen said, I don't think we're being good stewards of taxpayer dollars, the trust fund, the Medicare program generally. I think we really have to think about, how do we encourage kind of the right care in the right place and the right amount at the right time, but also how do we make certain that we're not seeing that fraud and abuse? And so with the 3-day rule, I think you need checks, and I think the big kind of risk there is that skilling in place that I mentioned earlier. Long-staying nursing home residents just getting turned over to post-acute. That works really well if you're an institutional special needs plan or a ACO, and you can manage that patient in the SNF and not down the street at the hospital or the ED. Works less well in terms of traditional Medicare fee-for-service, where it's less clear who's really managing the services and whether this is done for financial reasons. And so I really think you would need a lot of accountability there, not individuals coming from the community for that 3-day rule, but individuals who are long-stay nursing home residents. I think we're really going to have to keep our eyes on that. So that's one way to sort of build those guardrails. In terms of telemedicine, I won't spend a lot of time on this other than to reference once again that great Commonwealth Fund piece by Dr. Mehrotra and colleagues. They outlined a series of steps, like what are some guardrails here? What do we want to pay for, and where do we want to pay for it? I think once again, telemedicine is here to stay. I don't think we're putting, I don't know if you want to say the genie back in the bottle or going, it's there. People are really, really appreciating it. And I think it has real potential in long-term care settings to improve outcomes. But I don't think, once again, opening up the floodgates and just saying telemedicine can be paid for anywhere, anytime. I think there really have to be particular rules about what we pay and in what instances, in order to encourage those high value care and really protect, I think, the trust fund going forward.
Gretchen, I guess I would say about fraud and abuse, it feels like they've been playing whack-a-mole with kind of fraud and abuse forever, and it probably will continue to some degree. But the good news is that if you pay a prospective payment on some sort of value-based approach for taking care of a population, say of 500 people or 1,000 people, and you hold the providers accountable for number of days spent at home, percent days at home, family and patient experience, and total costs, there's not a lot of room there for fraud and abuse because they're actually accountable for good results. And then they can share. The other good news is that there's about probably at least 20% of Medicare costs in the high risk group that you could reduce in the total cost. So you can reduce total cost by a substantial amount. And then if the fraud and abuse even stayed the same, you'd still be ahead.
Great. Well, I want to thank both of our panelists today for joining us this afternoon. This has been a terrific conversation. For our attendees, please take the time to complete the evaluation survey that you'll receive after the podcast as well, and via email. And a recording of this webinar and additional materials will be available on the Alliance's website. David and Eric, thank you so much for joining us today. This has been a terrific conversation.
Thanks.
Thank you.